Hello guys, this is Dr. Turpin. I'm going to go through some of the key points that I know you've had an assignment to read the chapters related to end-of-life care and palliative care. And I know we've covered some of these things kind of in an ongoing way between fundamentals and when we talked about cancer care. A lot of these key concepts will not be new, but just to kind of make sure that we don't miss anything. So there's two kind of key concepts here, and one is caring for the dying patient and their family and providing family care at the point when the patient is really not so much you're still providing physical care, but you're probably providing even more care to the family at some point in the dying process. As well as finding ways to kind of care for yourself. Our last lecture is going to be related to complementary and alternative medicines as well, and that will be on the week we come back. And I hope to get that ready here in the next day or so as well. Anyway, let's moving right along here. We know that the average life expectancy in the United States is getting longer and longer. We're now up to an average lifespan of 78 years, and because of that, patients are living longer with long-term disabilities and more chronic disease, and the number of these folks are going to double by the year 2030. So in your first 10 years of working, you're going to really see a huge increase in this. So while it's been important to, be capable and knowledgeable, imagine that the potential for elderly dying patients is going to double. So this will become a much bigger part of care, even for general patient populations and not just focused on patients like cancer patients. So what is the difference between palliative care and hospice care? You hear those terms sometimes now sort of used interchangeably. I used to be the clinical director for the Hospice and Palliative Care Center in Winston-Salem, and because of that, there's been a huge change. It used to be that hospice care was very much when you went into hospice, you were almost at the verge of actively dying, and that no additional treatments were given, necessarily no palliative treatment other than pain control or pain management. And you had to sign and agree to be a DNR to even be admitted to hospice service. And so a lot of that has changed. So just know that history is there. Typically, to be able to have care provided by hospice, nowadays should be, care of dying as well as palliation of pain, other symptoms, and emotional stress from having a serious illness also. And hospice care is generally going to focus on a patient that has less than 6 months to live. If you are a Medicare patient, which a lot of our elderly patients are under Medicare, they have to have a doctor sign a certification form attesting to that the terminal disease that this patient has and that their life expectancy is considered to be less than 6 months. And that then qualifies them to get care from hospice. So when they're under hospice care by that entity, they can have care provided at home by a nurse that oversees care, and they send home health aides out. They can also be a resident in a skilled nursing facility who's deemed to have less than 6 months to live, and hospice can come in and provide services, and in that way they have a contractual arrangement between the skilled nursing facility and the hospice facility, and they work out. Medicare is billed by the hospice, but then the hospice pays for the bed at the SNF for the patient. So it's a very complex thing in terms of the financial management of it. So just know that there are some details I'm leaving out. And then occasionally patients, more and more, opting to go to what we call a hospice home. And a hospice home can have several beds in it. It can be set up for respite care if families need, under Medicare, it will cover if, say, the family need to have a 5-day break. It will cover for that periodically. And so they would bring their family member, arrange it with the hospice home that they're already under that hospice care at home, and then they can bring them to the hospice home and they can take care of that patient just as they would have been at home. That's one thing. The second thing is the hospice home might be a short stay place. Say they need to come in for some palliative type treatment. They might come there, get whatever procedure done, and then they may go home following it after a day of rest after that. And then the third time that you see people admitted to the hospice home is usually when the family's reserves in terms of and resources in terms of managing the patient at home under hospice care has either become just too much, whether that means they don't have enough people to stay with the patient around the clock in the family, or maybe family members themselves are sick that have attempted to be with the patient 24 hours a day. So there are some circumstances that it ends up being a better situation for the patient when they get closer to imminence of death to move from the hospice being provided in the home to the actual acute dying process to be done in the hospice home, and with support and people around to help the family members be there, but take away some of that care burden that they feel. If a patient should be certified for hospice and then they don't die in the 6th month, the doctor has got to do another recertification for another 6 months. And that usually is sort of okay in terms of Medicare if it's well documented, but you can't be kind of in perpetual every 6 months getting recertified because Medicare looks at that like, well, you're not doing a great job of being predictive with this in an ongoing way. So just know those are a few details. You will sometimes have families who really feel like going to the hospice home is going somewhere to just be put in there and give pain medications and allowed to die. And it's not meant to be that way. Sometimes family members don't see that there's a difference between going to the hospice home or to the skilled nursing facility, that the skilled nursing facility can provide all their needs, and that may be well true, but the goal of a hospice home is to really provide those care needs, and it is totally differently staffed. In a nursing facility, you might have one RN on the day shift for a fairly good size facility and some LPNs and different caregivers. But all of those folks have either tasks, like they're the med nurse, or they have a very long haul of patients that they oversee. In hospice care, often you will see there is one nurse to maybe 5 patients, like you would almost see in an acute care or hospital unit. And so it's really important to let families know when they're considering this that it's much more care and much more specialized. While there's not tons of medications given and lots of antibiotics and lots of therapies, that time that would have been used for those is rolled into much more positive interactions and communications and fairly constant pain management monitoring and trying to work with the families, as well as bring teams in from social work and case management and pharmacy and different disciplines to kind of work together to kind of get the needs of the patient met. So it is a different model of terms of, how much attention they should be able to receive. Your book gives you the domains of palliative care, and these are kind of based on national standards of, kind of breaking down different things that are expected in terms of palliation. So first is kind of like, how is care set up, where is it going to be delivered, and then all the kind of content areas that care would be given in, whether it's physical, psychological, social, in terms of how the client interacts with his social group, and then other things like spiritual, religious, or existential care that might be needed, how to work with cultural care that may be very specific for individuals going through death and dying, and then the actual care of the patient who is imminently dying, which is very complex at times, and then ethical and legal aspects of care. And I'll try to mention a few of these from the time we've got left here. Symptom management, we've already talked about this before and given examples before, but just know often when you're in a palliative care situation, it is really about what is the best method to alleviate symptoms, with being at least invasive really as you can. So you may see things like a PCA given for pain. Instead of trying to manage and keep an IV in somebody all the time, they might have that set up almost like a insulin pump that's been put in through a subcutaneous needle that's hooked to the pump, where they're kind of getting a dose that's going in that way versus IV. Sometimes you'll see them crush oral meds that in the hospital you'd never see us like give rectally, but a hospice nurse in the home, they may have to give it that way or that route because that's what works, and they don't want the patient's unable to swallow or do something at that point, and they don't want to, again, do invasive IVs and things. Patients may have pain and pressure from ascites or from fluid on the lungs. They might come into like a facility and get a paracentesis or thoracentesis done, not to cure that situation, but just to relieve pain and pressure, and then gradually that sort of builds back up. But it may improve their physical feeling about themselves. It may improve their work of breathing, and occasionally you have patients that really are having trouble with breathing and problems with just fatigue and everything related to low blood counts, and sometimes those patients might come in and get a blood transfusion just for to make the symptoms better versus settle the issue with their counts. We already went over a lot about family care and fundamentals. You'll remember that Dr. Lane came and talked about her experience, but her experience hits a lot of these things. You want to always assess the patient and family's understanding of the patient's diagnosis and that they are dying. Do they really know that? Have they been told that? Or have they, denied that in some way, or are they ignoring it? Other things are, making sure that you inform the family members that the patient is actively dying, or there are symptoms that go along with that, so that they have time to have a space to kind of think about how to handle that. They may need to make arrangements for other family members to come and be there. And you want to invite them to come and do as much with the patient as possible, just because that makes them feel like they're doing something for them at the last time. You should encourage them to bring in lots of their own things as well and make the area feel like as homey as possible and as comfortable as possible.